Hello everyone and welcome to our module on calcium, magnesium, and phosphate disorders. The normal range for the total amount of calcium in human plasma is 8.5 to 10 milligrams per deciliter. And anytime you measure the total serum calcium on a patient, you need to remember to correct it for the serum albumin. Calcium in the plasma can be found in two forms. Some calcium is bound to albumin. That's because albumin is negatively charged and calcium is positively charged, so albumin tends to bind calcium. And in addition, some calcium is found free. And it's this free calcium that exerts the physiologic effects. That's the important calcium in the blood. When you measure the total serum calcium, you are measuring the albumin-bound calcium plus the free calcium. And that's fine as long as the albumin level is normal. However, if the albumin level falls, then the albumin-bound calcium level will fall, but the free calcium level will not change. What that means is, in a patient who has hypoalbuminemia, the total serum calcium will be low. However, the free calcium can be normal, and you need to account for that. And so a normal serum albumin level is 3.4 to 5.4, and the way you correct the total serum calcium for patients who are hypoalbuminemic is for every 1 below 4 for the albumin, you add 0.8 to the total calcium. And if you follow this rule of thumb, then you can use this normal range even in patients who have low albumin levels. So to make this more clear, let's imagine that a patient has a calcium level of 7.8, which is below the lower limit of normal, which I told you was 8.5. Now let's imagine this patient's albumin level is 3.0, which is reduced. Well, according to the rule of thumb, for every 1 point of the albumin below 4, you can add 0.8 to the calcium. That will increase this patient's calcium from 7.8 to 8.6, which is actually within the normal range. So even though this patient has a low serum calcium, the calcium is actually normal when you account for the hypoalbuminemia. You also can directly measure the ionized or free calcium in the blood. This isn't routinely done because it's more complex than measuring total serum calcium. And the main instance where measurement of the free calcium is important is in patients who have an acidosis or an alkalosis. Remember that some calcium is bound to albumin, so when you have an acidosis, there's lots of H+ around. This H+ will bind to albumin and push the calcium off. So in a patient who has an acidosis, the free calcium level can get very high, even though the total calcium level may be entirely normal. And that's why in the setting of an acidosis or an alkalosis, this is when you really want to measure the free calcium to distinguish it from the bound calcium. So in an acidosis, the ionized calcium level may get high, even though the total serum calcium may be normal. The reverse is true in an alkalosis. The total serum calcium can be normal, but the free calcium level can be low. And therefore, patients can develop hypo or hypocalcemic symptoms, even though they have a normal serum calcium in the setting of an acid-base disorder. Let's start our discussion of calcium disorders by talking about hypocalcemia. So the key sign of hypocalcemia is tetany. So patients who have low calcium levels will have muscles that twitch. This is tetany. They will also have hyperactive reflexes. And then there are two very classic signs of tetany that are rarely seen in modern practice. One is called Trousseau sign. This refers to the hand spasming when a blood pressure cuff is inflated on the upper arm. Second sign is Schwastek sign. This refers to facial contraction when you tap on the facial nerve. Patients with hypocalcemia can also have seizures, so in any patient with a seizure, we check the serum calcium level. And then finally on the EKG, hypocalcemia will prolong the QT interval. So at the top of the screen is an example of a normal QT interval, which is anything under about 470 milliseconds, and this one here is about 400 milliseconds. At the bottom of the screen is a patient with a prolonged QT interval. The QT interval here is about 600 milliseconds. There are lots of potential causes of hypocalcemia, but I've listed some of the important ones on this slide. The first cause is low parathyroid hormone levels. So patients who have hypoparathyroidism have low PTH levels, and this leads to hypocalcemia. And the classic case of a patient with hypoparathyroidism is a patient who has had a recent thyroidectomy, and you always want to remember this for your boards. Often after a thyroidectomy for thyroid cancer or some other thyroid disorder, the parathyroid glands can accidentally be excised, and that patient will begin to develop tetany a few days later from hypocalcemia. Some patients with hypocalcemia have high parathyroid hormone levels, and in these patients the parathyroid gland is trying to raise the serum calcium level, but it's not effective. There are a couple of reasons this can happen. One is if you are deficient in vitamin D, because you need vitamin D to maintain a normal serum calcium level. This often happens in patients with chronic kidney disease. These patients have decreased active vitamin D because the kidneys are important for converting vitamin D to the active form. And then in patients who have pancreatitis, these patients saponify magnesium and calcium, which means that they pull the electrolytes from the plasma into necrotic fat. So these patients will develop hypocalcemia. And then later in this video, we're going to talk about magnesium, but a very high yield thing to know is that if you have very severe hypomagnesemia, this will inhibit parathyroid hormone release and effectively cause hypoparathyroidism and hypocalcemia. The treatment of hypocalcemia involves replenishing the calcium that's missing from the patient's system. But before you do that, you want to never forget to do two other things. First is correct any magnesium deficiency that is present, and the second is to supplement vitamin D. Beyond this, the treatment involves calcium replacement. For patients with a mild calcium deficiency, which most people consider in the range of 7.5 to 8.4, the treatment is usually with oral calcium. For patients with a severe deficiency or patients who have symptoms, the treatment is usually with IV calcium gluconate, which raises the plasma calcium much faster than oral calcium. Moving on, let's talk about hypercalcemia. This is a calcium level that is greater than 10, which is the upper limit of normal. And often hypercalcemia is asymptomatic unless the calcium gets very high, usually greater than 12. So because hypercalcemia is often asymptomatic, it's often identified in routine blood work rather than in a patient who has symptoms from hypercalcemia. One of the things to always remember about hypercalcemia is that it can lead to recurrent calcium kidney stones. And in any patient who has multiple kidney stones, checking the serum calcium is one of the standard things to do. Another thing to always remember about calcium is that acute hypercalcemia, especially if the calcium gets very high, leads to polyuria. That's because calcium causes nephrogenic diabetes insipidus. It blunts the ability of the kidneys to concentrate urine. It leads to excessive free water excretion. So if you ever meet a patient with hypercalcemia, they will tell you, I'm thirsty and peeing all the time. That is a classic patient with acute hypercalcemia. In addition, because of the volume loss from all the diuresis, these patients can develop a fall in GFR and acute renal failure, also from hypercalcemia. So the mnemonic for remembering the symptoms of hypercalcemia is stones, bones, groans, and psychiatric overtones. In reality, most of these symptoms are very rare. They're largely historical from the era before we could identify and treat hypercalcemia. So stones refers to the renal complications of high calcium that we just talked about: polyuria, recurrent kidney stones, and renal failure. Bones refers to bone pain because many patients with hypercalcemia have bone pain. Groans refers to abdominal pain. High calcium shuts down the motility in the gut, so these patients can develop constipation, anorexia, nausea. And then finally, hypercalcemia can cause psychiatric changes, so patients can feel anxious or develop altered mental status. The two major causes of hypercalcemia are hyperparathyroidism and malignancy. The majority of outpatients who have high calcium are going to turn out to have primary hyperparathyroidism. That's the most common cause. Other causes are shown on this slide. Hypervitaminosis D refers to massive consumption of supplements of calcitriol, the active form of vitamin D. This is very uncommon, but patients who take huge amounts of vitamin D can develop hypercalcemia. Granulomatous diseases like sarcoidosis are a classic cause of hypercalcemia. That's because the macrophages in granulomas have 1-alpha hydroxylase. This is the enzyme that activates vitamin D. So these patients will get a very high level of active vitamin D in the plasma, and that will lead to hypercalcemia. And then a final cause of hypercalcemia is the milk alkali syndrome. This is very rare in the modern era. It's largely historical. Years ago, before there were good treatments for stomach ulcers, patients used to take lots of calcium carbonate, sometimes together with milk. And when they did this, they'd be taking in lots of calcium plus alkali because carbonate is a base. So this combination would lead to hypercalcemia. The alkali would cause a metabolic alkalosis, and then the hypercalcemia would cause polyuria, and that would lead to volume depletion and renal failure. So this triad was often seen in patients who were drinking lots of milk and taking lots of alkali, like something for stomach ulcers. For most patients with hypercalcemia, the treatment is simply to treat the underlying condition, to resolve the hyperparathyroidism or the malignancy. If the calcium elevation is severe, and severe is usually defined as greater than 14, or if the patient has symptoms of hypercalcemia, then there are a couple of treatments that can be used acutely in the hospital. The first one is intravenous normal saline. Remember that patients with hypercalcemia become volume depleted, so they need fluids. You can administer calcitonin, which you may know is a hormone produced by the thyroid gland. It lowers serum calcium. It has a minimal role in normal physiology of calcium, but if you give high amounts as a drug, that will reduce the serum calcium level. And then lastly, bisphosphonates, especially intravenous bisphosphonates, are used for hypercalcemia. These drugs keep calcium bound in bones, and so they're useful in patients with osteoporosis, but they can also lower the serum calcium level in patients who have hypercalcemia. Moving on, let's talk about magnesium, and we'll start by talking about hypomagnesemia. The normal range for plasma magnesium is 1.8 to 2.5 milliequivalents per liter. And when the magnesium level gets low, the symptoms that can develop are very similar to the symptoms of hypocalcemia. Things like neuromuscular excitability with symptoms like tetany and tremor. The QT interval can prolong and cardiac arrhythmias may occur. Two special things that happen when magnesium is low, however, are hypocalcemia and hypokalemia, and it's very important to remember this. Magnesium is related to the metabolism of calcium and potassium. We'll talk about why in a minute, but what this means is anytime the mag level is low, the level of calcium and potassium is also going to get low. The reason hypomagnesemia causes hypocalcemia is because magnesium has important effects on the parathyroid gland. If your magnesium level gets a little bit low, this will boost the release of parathyroid hormone, basically having the same effect as calcium. And this will increase the GI and renal magnesium absorption along with calcium. And this is part of how the parathyroid gland helps to maintain normal calcium and magnesium levels. However, paradoxically, if the magnesium level gets very low, this will inhibit parathyroid release. That's because there is a receptor in the parathyroid gland called the CASR, and it needs magnesium to work. So if there isn't enough magnesium around and the level is very low, the CASR will function abnormally and it will suppress the release of PTH, and this will lead to hypocalcemia. So the bottom line is what I've written in bold here, that hypocalcemia is often seen in severe hypomagnesemia. And so when anyone has hypocalcemia, you need to consider that their magnesium level could be the problem and you need to check the magnesium level. Hypomagnesemia also has important effects on potassium metabolism. In particular, magnesium normally inhibits potassium excretion. This is part of the normal physiology of the body. The reason this is the case is because there is a channel in the kidneys called the ROMK channel. This stands for the renal outer medullary potassium channel. It's found in the cortical collecting duct. And what this channel does is allow potassium to diffuse out into the urine and then go out and be excreted. Magnesium normally inhibits the function of this channel, so the body will hold on to potassium. But when magnesium levels get low, in other words, when there's hypomagnesemia, then lots of these ROMK channels are going to be functioning and lots of potassium is going to go out into the urine. This means that hypokalemia often develops in patients who have hypomagnesemia. This also has important relevance clinically because the potassium can't be corrected until the magnesium is corrected. As long as the magnesium level is low, you can give the patient lots of potassium, but it will continue to go out in the urine. You've got to fix the mag first. So in any patient who has hypokalemia, one of the things you want to do is check the magnesium level and make sure you correct that if necessary. If you don't, you will never be able to resolve the hypokalemia. There are many causes of hypomagnesemia. I've written some important ones on this slide. You can lose magnesium if you have GI losses because GI secretions contain magnesium. So patients who have diarrhea often develop hypomagnesemia. Diuretics act on the kidneys and cause magnesium to go out in the urine, especially lupin thiazide diuretics. So patients on these drugs can develop hypomagnesemia. And then finally, a classic cause is malnutrition, which often occurs among patients who are heavy alcohol users. Alcohol causes tubular dysfunction in the kidneys and causes magnesium wasting. So patients who drink lots of alcohol and don't eat very much often come into the hospital with hypomagnesemia. And the treatment for hypomagnesemia is very straightforward. There are oral and intravenous preparations of magnesium. Next, let's talk about hypermagnesemia. This occurs anytime the magnesium concentration is above the normal range, which is greater than 2.5 milliequivalents per liter. To remember the symptoms of hypermagnesemia, just know that magnesium blocks the effects of calcium and potassium, so most of the effects relate to these electrolytes. So by blocking the effects of calcium, there can be neuromuscular toxicity with things like decreased reflexes and paralysis. By blocking calcium and potassium in the heart, this can lead to bradycardia and hypotension and even cardiac arrest. And then remember that magnesium and calcium are right next to each other on the periodic table. That's an easy way to remember that they both have similar effects on the parathyroid gland. So when the magnesium level goes up, the parathyroid gland will stop secreting PTH, the same way it would do if the calcium level went up. And this is going to lead to hypocalcemia. So hypocalcemia often occurs with hypermagnesemia through inhibition of parathyroid hormone secretion. So magnesium has tricky effects on the parathyroid gland. If the magnesium level is high, you get hypocalcemia. And then, as I said before, if the magnesium level is very low, that also can shut down parathyroid hormone release and lead to hypocalcemia. There are a couple of treatments that can be used for hypermagnesemia. First of all, many drugs contain magnesium, so you want to talk to the pharmacist and stop any drugs with magnesium in them if the patient has hypermagnesemia. You can give normal saline and loop diuretics. Loop diuretics cause magnesium to go out in the urine, and by administering normal saline, the patient does not lose volume, they only lose magnesium. Calcium gluconate stabilizes the myocardium. It's used in patients who have hyperkalemia, but you can also give this in patients who have hypermagnesemia, and that will reduce the risk of the patient developing any cardiac effects of hypermagnesemia. And then finally, the ultimate treatment for hypermagnesemia is dialysis. In patients who have a magnesium level that you can't get down and they have severe renal insufficiency, those patients need dialysis. Last electrolyte is phosphate. So a normal serum phosphate level is 2.5 to 4.5 milligrams per deciliter. And the main symptom of hypophosphatemia is weakness. It's because if you don't have phosphate, you can't make ATP. The P in ATP is for adenosine triphosphate. So you need lots of this to have normal ATP levels. What this means is when the phosphate levels are low, you're going to get weakness. And the way that's going to first present usually is with respiratory muscle weakness. So patients will complain of difficulty breathing, and that's because they have low phosphate levels. If the phosphate level is chronically low, this can lead to bone loss and osteomalacia. This is because the body will pull phosphate from the bones. Shown on this slide are some of the causes of hypophosphatemia, and the first one is primary hyperparathyroidism. So when the parathyroid gland is overactive, the serum calcium will rise, which we already talked about before. But in addition, parathyroid hormone causes more phosphate to go out in the urine, so the phosphate level will fall. So the typical profile of someone with hyperparathyroidism is a high calcium level and a low phosphate level. Patients with diabetic ketoacidosis develop hypophosphatemia. That's because the high glucose level causes an osmotic diuresis, and this causes more phosphate to go out in the urine. And then finally, a classic cause of hypophosphatemia is the refeeding syndrome. So if someone has had very poor nutrition and you start feeding them again, that patient already has low phosphate when you start to feed them. The food intake stimulates metabolism, and that drops the phosphate level further. That's because the body starts to make ATP and starts to activate other metabolic pathways. So for this reason, when you begin refeeding someone who has poor nutrition, you have to do that carefully, and you have to monitor and supplement the phosphate levels. So this could be a person who is a heavy alcohol user and is malnourished. It could be a person with an eating disorder who is beginning to eat normally again, or it could be a person from a country where there is famine. In all of these situations, that patient is at risk for the refeeding syndrome, and the problems that can occur are because of hypophosphatemia. And the treatment is very straightforward. There are oral and intravenous phosphate replacements that are available. Hyperphosphatemia is when the phosphate level is above the normal range, greater than 4.5 milligrams per deciliter. Most patients who have hyperphosphatemia are asymptomatic. If they do develop signs and symptoms, it's usually from hypocalcemia, and that's because when you have lots of this phosphate around in the plasma, it binds to calcium and pulls calcium out of the plasma, so hyperphosphatemia can precipitate symptoms of hypocalcemia. The major cause of hyperphosphatemia is acute and chronic kidney disease, and I'll talk about why this happens in just a minute. A second cause is hypoparathyroidism. So parathyroid hormone inhibits phosphate reabsorption and causes phosphate to go out in the urine. So when the level of PTH is low, then the kidneys are going to hold onto phosphate and excrete less, and this can potentially cause hyperphosphatemia. And then another cause of hyperphosphatemia is a phosphate load. So if someone has leukemia and gets chemotherapy, all their tumor cells will lyse and spill phosphate into the blood, and this will cause hyperphosphatemia. This is one element of what's known as the tumor lysis syndrome. If a patient has rhabdomyolysis and has diffuse muscle damage and necrosis, those muscle cells will spill phosphate into the plasma, and that will cause hyperphosphatemia. This can also happen if patients take lots of phosphate laxatives. For example, there is a laxative sometimes given to patients to prep the bowel for colonoscopy. It's called Fleet's phosphosoda, and some patients who take lots of this can develop hyperphosphatemia. Shown on this slide is what happens to calcium and phosphate metabolism in patients who have chronic renal failure. So when the kidneys are sick, they cannot excrete phosphate normally, and hyperphosphatemia develops. In addition, sick kidneys cannot activate vitamin D, so there's a fall in the active form of vitamin D, and this causes less calcium to be absorbed from the gut. In addition, as I told you before, when phosphate levels are high, calcium is pulled from the plasma. So for both of these reasons, hypocalcemia develops in patients with chronic renal failure. And then finally, when the calcium level is low, this triggers parathyroid hormone release, and that leads to a form of hyperparathyroidism called secondary hyperparathyroidism. So the classic profile of a patient with chronic renal failure is high serum phosphate, low serum calcium, and high parathyroid hormone levels. So what happens to chronic renal failure patients who walk around for months and years with hyperphosphatemia? Well, what happens is they can develop what's known as metastatic calcifications. It's also called calciphylaxis. This only occurs in patients with chronic hyperphosphatemia from chronic kidney disease. The high phosphate in the plasma gets taken up by vascular smooth muscle and pulls calcium in with it, so you get osteogenesis. Basically, you get bone forming inside of vascular smooth muscle, and as a result, the vascular walls become calcified. This can raise the systolic blood pressure, and these patients can be very hypertensive. In addition, it can cause small blood vessel thrombosis, and this often happens beneath the skin, and these patients develop painful nodules in the skin from hyperphosphatemia. This is a picture of what one can look like. This patient has thrombosed vessels in their skin, and the reason this is happening is because of chronic hyperphosphatemia. This is an example of the process of calciphylaxis or metastatic calcifications. So in patients with chronic kidney disease, you don't want them to get calciphylaxis. So what you do is you advise them to eat a low phosphate diet. This is one component of a renal diet. And you also prescribe drugs called phosphate binders. These are drugs that bind phosphate in the gut and prevent it from being absorbed, and they are used in all patients with chronic kidney disease. Some of them include calcium carbonate, calcium acetate, which is also called Foslo, sevelamer, which is called renal gel, and lanthanum, and there are others. But any patients you take care of in the hospital will be on one of these drugs, and the idea is this is to bring down the phosphate level so they don't walk around with hyperphosphatemia and they don't develop all the complications we talked about in the last slide. And that concludes our module on calcium, magnesium, and phosphate disorders.